So let me introduce our next speaker. So how to pronounce correctly your name? Xiaowei will will speak about future perspectives on speech intelligibility in practice.
Thank you, Yuli. Good morning, everyone. Nice to see you again on the second day of the TAPAS final workshop. Today, I want to talk about my future perspectives on speech intelligibility in practice. And if people have attended our first day, you may already know about this concept of speech intelligibility. Today, I want to start it a little bit different perspective that, in fact, this concept of intelligibility has been studied and explored in many different disciplines. They share the same name, but they have been approached this concept from different perspectives with respect to the classic communication chain. So here's a picture of what is a kind of classic communication chain. It's pretty normal that we face this every day, that a speaker generates a speech signal, and there's a transition channel like our phone when we do a phone call, or a computer, or even when I'm talking in this large room, you may hear my sound very differently because I'm using this kind of speaker. And yeah, and also like when we have our dinner last night in a restaurant, it's kind of have a lumbar speech because you have a lot of noise, you have other people talking to each other on the background. And then also a speaker, also a listener who perceives the speech. So in these four disciplines I present here, the speech pathology, second language learning, telecommunication, and the audiology, they all approach the intelligibility slightly differently. For example, so in telecommunication, the researchers in this discipline, they mainly focus on the losslessness of the transition channel that caused on the speech intelligibility. So you may have read in literature that they kind of measure the signal to noise ratio to measure the intelligibility. While in audiology, people more focus on the impact of like hearing impairments on the perception of intelligibility. While in speech pathology and second language learning, researchers more focus on the speaker properties, such as like having dysphasia, like we have heard a lot yesterday, in speech pathology, or like you have a L2 accent that your mother tongue may have influence when you're talking another language. Today what I want to share my perspectives more focus on the speech pathology discipline, that the deviations caused by dysphasia. So you probably have seen this picture yesterday, that what is dysphasia and what is speech intelligibility. So briefly refresh your mind, remember that dysphasia is a group of neurological disease caused by neurological disorders such as Parkinson's disease or brain injury like stroke. So people who have dysphasia, they normally suffer from losing all control over the muscles of their speech production system. And consequently, they have abnormalities in their respiration, like what Srikant showed yesterday, or their intonation, their articulation, etc., and cause abnormalities in their speech, strange speed, range prosody. So people who have dysphasia, because of this consequences, they gradually lose contact with the others and eventually becoming isolated from the social life and society, which have a great impact on their quality of life. So what they can do is that they can go to the rehabilitation center or hospitals to take speech therapy. And in that case, they can practice to help them slow down the degrees of intelligibility, or maybe even help them to have a little improvement in intelligibility so that they can communicate well with others. So to measure the effectiveness of therapeutical treatment, it's always necessary to have a very clear definition of what intelligibility is. And we actually have some discussion yesterday, but I'm not going to dive into detail about that. So briefly, intelligibility in our group mainly refers to how well a speaker's acoustic signal can be accurately recovered by a listener. So based on that, it's pretty common that intelligibility has been measured through subjective procedures. So it's still being used in clinics or in research setting, that you conduct some listening experiments, you collect a group of recordings from speakers with dysphagia, that they may have varying levels of severity or different dysphagia type. You ask them to read something, and then you ask a group of listeners trying to listen and trying to give their perceptions on that in terms of intelligibility. However, this kind of evaluations or assessment is very time consuming, as we can see, and that's why we have this TAPAS project that we're trying to automate those procedures. So in fact, there have been a lot of research and also other technologies been used to automatically evaluate intelligibility. Some of them are based on acoustic features, as you have seen from Timothy's presentation, and also aside from those consonants, acoustics features, there are also other features that have been used a lot or studied a lot and have shown some relation with intelligibility, such as vowel space area. So people have that dysphagia, they cannot place their tongues properly, so that they normally have reduced the space of vowel space area. And also others like second phoneme frequency slope or speech rate, like Parkinson patients, they normally have abnormalities in their speech. So they sometimes speak very fast, sometimes speak slower, and that is unpredictable. And there are also other many different sophisticated machine learning techniques has been used to assess intelligibility, such as start from the very traditional pipeline ASRs, where you have acoustic model, language model, and a dictionary, and then comes to the hybrid ASR, where people incorporate the technology of deep neural networks. And even more modern, the state-of-art ones that you use different end-to-end models. And these kind of models or studies have report pretty high correlation with perceptual or the subjective intelligibility measures. So that's, on the one hand, is pretty good news to know that we're approaching more and more. Once we have the evaluation of intelligibility, it comes to the place that we need to give them a therapy. That's the most important thing for the patient, that they want to improve their intelligibility to help themselves. And the clinicians may give different therapy treatment plans to speakers who have different symptoms, which is understandable and expected. And also, it requires a long-term and intensive therapy. This has been shown and reported to be effectiveness in clinical practice and also in literature. However, this kind of therapies can be time-consuming, costly, and fatiguing for both therapists and the patients. Not only the assessment and the therapy themselves, but also like the patients have to travel a lot to the rehabilitation center, to the hospital. So based on that, there's more and more people have started to incorporate speech technology to build up those kind of applications. So I want to give 2 examples here. The first one we have seen is presented by Viviana yesterday. that is a virtual articulation therapy where the users can choose which phonemes they want to practice more, and they can also visually see how this is pronounced. And after that, they can also see their acoustic signal of the word they have practiced. Another example I want to present here is it's a serious game called Treasure Hunter. It has been developed by my colleague at Radboud University, Hans Bohm, and my supervisor Helmer and their colleagues. So in this game, it's kind of like there's an interaction between two speakers that they communicating with each other and they're trying to find the treasure and get the treasure. As you can see here, it's an overview or the interface of the game itself. And on the top, there's a red word saying speak louder. And when they speak louder, the green circle will go larger. So you can view the background more clearly, so you can see where the treasure is. So based on this, the speakers getting to speak louder and louder, which has been shown to be effectiveness for Parkinson patients. And in this game, they also have some extra practice. After they have done this intervention, they have also studied whether this do help the users or the speakers to have any improvements in their speech intelligibility. So in this figure, you can see that the different colors is for different speakers, and they have 3 different times to do a pre and post test. So the T1 is like 4 weeks before the game, and T2 is just before the game, and T3 is just after the game, which is also 4 weeks. So it's kind of intensive and a little bit longer therapy. And you can have seen that for most of the speakers, there are some improvements in the intelligibility. So we have seen that there have been a lot of progress made for both assess intelligibility, while to reduce effort that the clinicians have, and also some computer-based therapy applications to help the users to practice. And these kind of technologies or applications are pretty quick, cheap, easy to use, and it's possible to assess from anywhere at any time. However, what I can see that these evaluations on the left side and those therapies on the right side are pretty separated. So there's no link or connection between each other where if there's something can be achieved for that, can have a great help for both the clinicians and the speakers. Because if we integrated these 2 kinds of technologies, like the automatic intelligibility assessment and the computer-based therapy into one application, so they can, on the one hand, test themselves to monitor how the speaker's diseases progress or how intelligible they are. And on the other hand, once they have the evaluations, they can do some therapy also on the same application. And what's more important is that based on this intelligibility assessment and these virtual therapists, they can regularly monitor themselves in the long term. And in that case, this assessment or the therapy can be shared with a therapist or hospital. So the clinicians can monitor remotely how's it going in their patients. And also, like when the clinicians evaluate those assessment report or the therapy outcomes, they can also try to modify what kind of further therapy the speakers and the patients need. And then that can be repeated, the monitor and therapy circles. So the good news is what I can see from here, that there have been some applications, maybe not for disaster, the whole population, but like what Camilo and Thomas just presented, and also what another Toma has presented yesterday, that they trying to include the clinicians in the whole therapy or assessment circle. Yes, so that's my idea. And I think in that case, it will help a lot, and hopefully to hear your remarks and comments this afternoon. Thank you.